Thank you very much. It's really an honor and a pleasure to join everyone today, and thank you for your attention. I was invited to give a talk on management of surgical infection, so it's a pretty broad topic, but I tried to break it down into sort of focused areas. So we'll go through my talk, but hopefully we'll have plenty of time to have time for questions. So without further ado, I will I'll share my screen and sort of get started here. Just okay, so you should all be able to see the PowerPoint. Is that correct?
Yes.
Great. All right. So so management of surgical infections, just a little bit about my background. I'm a general surgeon, also trauma critical care. My areas of interest are actually in surgical infections, so most of my research is related to that, and you'll see some of the work we've done in that area. So nothing to disclose. I'd like to just kind of give you an introduction of what we'll talk about. I'm going to talk a little bit about, if we talk about surgical infections, we should first talk about prevention, and then we talk about appropriate management. A lot of that comes down to sort of preventing infections, which is, a little brief history of antisepsis, and then really talking about evidence-based approach to prophylaxis, which is a huge part of preventing infections. And then really kind of focusing on an area where maybe you didn't think we'd talk about today, but as surgeons, we need to be antibiotic stewards because we actually use a lot of antibiotics, which sometimes you don't think about us as surgeons. I mean, we really add to the antibiotic resistance that's we're facing globally. And then talk about treatment of sort of intra-abdominal infections and necrotizing soft tissue infections. And a lot of my actual area of interest in research is in the immunocompromised host. So where there's very little data and a lot of data is very lacking when it comes down to how do you manage best a surgical patient that's immunocompromised. So, the history of sort of antisepsis goes all the way back to the Hippocrates days, where it's actually described using wine and vinegar to irrigate wounds to help sort of help with their healing. And it wasn't until much later, and it was actually an OB obstetrician, an Austrian obstetrician, Dr. Semmelweis, who in the 1800s actually discovered that hand washing with carbolic acid, of all things, actually before delivery, actually led to dramatically less infections. Not really infections, because at this point, we didn't know about the germ theory yet, but also just that showed that there's less people dying once we did that. Of course, he was deemed a lunatic and was institutionalized and passed away while in a straitjacket. And it was Louis Pasteur who first came up with recognized this idea of germ theory. And I know you guys probably all know this little bit of history, but that microorganisms were responsible for infections in humans and causing disease. And it wasn't until a little bit later in the mid-1800s to 1900 where Joseph Lister was an English surgeon, he was aware of Louis Pasteur's germ theory. And basically he reasoned that if airborne microbes could, like sour milk and rot meat, then they probably are responsible for causing wound infections. So actually this was the pioneer of really the birth of antisepsis, because he introduced disinfecting the operating room theater with carbolic acid, again, going back to carbolic acid, and came up with this Listerine antisepsis. And really this was revolutionary in trying to lessen infections that were particularly like wound infections and such. Interestingly, though, the adoption of antisepsis procedures took a little while, but it did come around and was able to start to gain gain acceptance. Now, it wasn't until fast forward to middle 1900s where we had, I don't know if anybody recognizes this, but this is Sir Alexander Fleming, who discovered basically penicillin, the antimicrobial bacterial properties of penicillin, probably the single greatest contribution to the evolution of modern medicine. And this was in the 1920s. However, the actual mass production of penicillin didn't really take hold till about World War II in the 1940s, where it was used actually and saved the life of many combat-related infections. And really, so it wasn't until 1947 where they started to use it. And by the 1950s, we already saw a significant amount of resistance to penicillin. And so that was already the beginning of seeing, yes, we have an antibiotic, which this was probably the biggest thing in medicine to help combat infections, but we already had significant amount of antimicrobial resistance. And a lot of my talk is focusing on this because this is really, when we have infections, we have to use antibiotics. And then the question is, we're running into more and more issues with worldwide with antimicrobial resistance. How did resistance comes about? Really two ways. We know about C. diff, which is a normal non-pathologic organisms that becomes pathologic in the setting of a abnormal host response, or it's more commonly the antimicrobial resistance comes about from antibiotic use and often abuse or misuse. Such things as extended spectrum beta-lactamases, MRSAs, and CA MRSA, which is community-acquired MRSAs. And if you just show you some of this data, it's pretty eye-opening to see. Here's just some of the Nordic countries' data on MRSA resistance, and you can see the sharp increase in resistance that we're seeing. This kind of graph is really similar to worldwide data more and more we're faced with dealing with antimicrobial resistance. This is looking at carbapenem-resistant isolates. This is data from you can see both worldwide and the US, and you can see that there's a very high increasing level of getting the ESBLs and carbapenem-resistant organisms. So antimicrobial resistance is a growing concern that affects really everybody, and particularly as surgeons, we have to deal with it when we have to deal with infections in our patients. And then lastly, some of the data, this was pretty fascinating. 1.2 million people have died in 2019 from antibiotic-resistant bacterial infections. So you may ask, what does this have to do with surgeons and surgical infections? But I would say that what is the solution, and how can we as surgeons be help with this problem in dealing with our infectious outcomes? So one of the things that we should all be cognizant of is to be good antibiotic stewards. And what does that mean? To be a good antibiotic steward, it means that you want to be able to use antibiotics appropriately. You want to have the right antibiotic for the right patient, for the right time, for the right duration, and for the right dose, really. And really try to limit unwanted use and excess use of it. So really, it's a system that ensures each patient receives the right antibiotic at the right time, at the right dose, like I mentioned, for the right duration. So we're going to talk a little bit about what we should be using in surgery, when we should use it, how long we should use it. And that's really the focus of my talk today. So again, we're going to talk about the evidence-based use of antibiotics for surgical prophylaxis and also treatment of infections. Now, all of you are aware that we use surgical prophylaxis in our operating rooms on a daily basis to combat basically the most common infection we have to deal with is surgical site infections. So, looking at surgeons and how much antibiotics we use, there's interesting data here. Like an institution, a hospital, actually 50% of its institution's antimicrobial prescribing comes from surgeons. And so you can imagine how if you're misusing it or, of these antibiotics can affect your hospital, your flora, could create resistance, and ultimately lead to death from infections. And even though we have a lot of evidence-based guidelines as to what to use, when to use, we still have a lot of misuse of it. So I'm going to review a little bit of that going forward. Here's just one paper out of JAMA, from 2014, just looking at how much surgical use of antibiotics in this patients in the surgical critical care unit had the most prevalence. This was just a prevalence study to look at basically a one-day prevalence of how much antibiotics were being used in this hospital, in acute care hospitals across 10 acute care hospitals. So showing you that as surgeons, we use a fair bit of the antibiotics. Now, surgical site prophylaxis, we know that there have been two advances along the way that have decreased surgical site infections. Number one is the antisepsis, right? So, and that made a huge progress in decreasing surgical site infection. And number two is probably the most important thing, is the use of prophylactic use of antibiotics. Probably has had the single greatest effect on development of SSIs. There's other things, obviously hypothermia, patient-related factors that affect it, but this has probably been the most important improvement. Now, SSIs are common. They account for 40% of all healthcare-related associated infections in the surgical population. So they still remain a big problem. Risk factors, you all know this, but there are patient factors, older patients, immunocompromised patients, diabetics, obese patients, those who are malnourished, and smokers generally have the highest risk of developing surgical site infections. There's obviously local factors, which is skin prep, which we talked about, and then the hypothermia and hypoxia. There's some data that shows that if you can prevent hypothermia, both pre-op, intra-op, and post-op, you can actually decrease SSIs. And the most important one is probably inappropriate or inadequate antibiotic prophylaxis. And then lastly is resistance, or sort of microbial factors. Now, what's the evidence from surgical site prophylaxis? It may seem straightforward and easy, but again, if you look at your hospital data, and there's still a significant amount of misuse and overuse of antibiotics when it comes to surgical site prophylaxis. So the most important factor is two things. You want to have spectrum of coverage, and you want to have timing of administration. So, if you have a patient, it's weight-based. So, if the patient is, often everyone gets, 1 gram of cephalosporin, but, if they're over 80, they should really be getting a higher dose. So 2 grams is really what's recommended. And then redose. How many times have you asked in the OR for your patient to be redosed once the case goes beyond, 4 hours or so? So really thinking about redose. As a trauma surgeon, oftentimes we have multiple, patients who undergo multiple transfusions. There's really no good data to show, like, when should we redose these patients who are in the OR for several hours and they're getting many units of blood. And then timing of administration, there's definite data that shows that the best result for surgical site prophylaxis happens if you can give it within 60 minutes of incision. There's some but not full benefits if it's given before the incision, so after the incision is made. It's generally, by then it's a little too late, but there is some benefit. And then there's really no benefits of continuing these prophylaxis beyond the perioperative doses. And we'll talk about that in a little bit more detail. So there's some controversial areas. Obviously, the CDC, the Center for Disease Control, does recommend that these, cases where you're going to be putting foreign bodies in, like prosthetics and such, neurosurgical patients, cardiac cases, orthopedic procedures, all should get prophylaxis. There are some controversial areas, which are breast surgery and herniography. So we know that these are both clean cases, and the question becomes, should these patients get prophylaxis, and if so, for how long? There are many randomized trials that show that breast cases, these are meta-analyses that show that a first-generation cephalosporin within 60 minutes does decrease risk of surgical site infections, and that they don't need to be continued longer than 24 hours, and they certainly don't need to be continued until drains are removed. I put that in there because a lot of the practice that I still see today is that these patients will be kept on antibiotics because they have like a JP drain or a Blake drain or some kind of a drain in place after breast surgery, which is absolutely not indicated to keep the antibiotics going, and there's no data that actually supports that. Now, hernias are controversial in a sense that, again, clean cases, but you are putting in a foreign material. If you actually look at the data, many trials have failed to show any benefit of antibiotic prophylaxis. And there are meta-analyses that have failed to demonstrate the effectiveness of antibiotics. And even if you're putting in mesh, unless the patient is high risk, where you're looking at those risk factors that we talked about, immunosuppressed, obese, smokers, diabetics, that may benefit. It's interesting that the European Hernia Society doesn't recommend routine use of antibiotic prophylaxis as well. However, there was one recent randomized, not recent, but several years ago, another randomized controlled trial came out. This was the study and published in the American Journal of Surgery. This was from Japan, and they looked at use of antibiotics for clean hernia repair cases, and they showed some benefit in that patient population. It was randomized control. So I think still remains a bit of a controversial area where I think more data will be needed. But there's sort of conflicting data out there. There's definitely some randomized control trials that don't recommend it. There's societies that don't recommend it. However, if they're potentially high risk, then it is recommended. Probably the worst SSI, with the most morbid SSIs are those from cardiac procedures. So mediastinitis that can occur because of an SSI after cardiac surgery carries a 20-fold increase in length of stay and a 5-fold increase in costs and 40% in hospital mortality. Those are staggering numbers. So certainly for these procedures, you do want to give prophylaxis. The question is what and for how long. There still remains some debate as to how long we should do it, but most of the benefits seem to be diminished after 48 hours. So really, beyond 48 hours, it's not recommended to give SSI, prophylactic antibiotics after cardiac surgery. And in fact, most of the data points to developing more resistance, which you would imagine makes sense. And the Society of Thoracic Surgeons recommends continuing for 48 hours. And then the question becomes, should you give a glycopeptide versus a beta-lactams, giving vancomycin for some of these patients. And again, the CDC recommendations say you should go with the beta-lactam unless you think you have an institution where your beta-lactam resistance is high, or if the patient's already, that the patient's already colonized with MRSA. And then I think contaminated cases, elective colorectal surgery patients, I think obviously we all try to give antibiotics perioperatively, but really patients that are coming in for elective colorectal surgery should also be getting oral treatment as well. So both oral and parenteral, and the oral should be given sort of the day before with a combination of neomycin and erythromycin or metronidazole, and then intraoperatively peri-op before incision, ideally 60 minutes before, or within 60 minutes of incision, that you would give a cephalosporin as well. And again, that's the whole idea of the prepping these patients. Bowel prep is a whole different discussion, but definitely, if you can, giving the oral antibiotics the day before. And for trauma, the Eastern Association of Surgery of Trauma, so the guidelines for trauma say, even though patients come in potentially with a hollow viscous injury, the evidence says that even for penetrating trauma, single perioperative dose of antibiotic for broad spectrum is adequate, and you don't need to continue it longer. And there's actually many papers that have looked at longer duration of antibiotics that have failed to show any improvement from this. Now, so far we've talked about prophylaxis. So, but prophylaxis accounts for a large percentage of antibiotics used, and appropriate prophylaxis is probably been, again, mentioned, shown to decrease surgical infections, probably has had the greatest effects in decreasing surgical infections. What about actual treatment of surgical infections? And I'm going to talk about the evidence. And really here, this is an area that I'm very passionate and done a lot of work on over the years. How long should you treat an intra-abdominal infection? So someone comes in with an abscess after a procedure, or someone comes in with a perforated diverticulitis that has an abscess that you're going to drain. You're going to treat, whether it's operative treatment versus drain treatment, whatever it is, IR, what is the appropriate duration of antibiotics? And then sort of also touching base upon what if the patient's immunosuppressed as opposed to the immunocompetent patient. So here's a case. Yeah, a 66-year-old presents with a perforated large bowel obstruction, undergoes surgery. You can see the colon was massively dilated because they had a distal large bowel obstruction that perforated. There's significant spillage once you go in. You wash the patient out, you give them a colostomy, or actually in this case, an ileostomy because it underwent a subtotal colectomy. So what would you say, just keep a number in your head. I can't really poll you here. So what I would say is, how many days of post-operative antibiotics would you treat this patient with? 24 hours, 4 days, 7 days, 14 days. And then I put in E as in the patient's physiologic parameters have normalized. So they have a normal white count and no fever. So I can't see everybody on the screen, but a show of hands, how many would say A? At least I have some people on the screen. How about B? C? Okay, some C. And D? All right. And then E? Anybody believe in? Okay, so all right. Well, thank you for participating. I know it's hard with this virtual format, but all right. So I think there's definitely going to show you some data on sort of what I think is probably the better answer of those. And then what if the same patient? I don't want to make it complicated, but what if the same patient, but now they were immunosuppressed, so they had a Bolt, which is a bilateral lung transplant, so they're on immunosuppression. Same patient comes with a colonic perf. Would you alter how many days of antibiotics you would give them? And so the same choices. How many people would favor a longer course of antibiotics in this case? And if so, how many would say, I'll start backwards. How many would choose 14? And then anybody would choose 7? How about till they're like white counts normalized? Would anybody just do 4 days? Nobody? Anybody? All right, let's go through some of the data. So how long should you treat an intra-abdominal infection? We know intra-abdominal infections are a big problem. We deal with them every day. You have, this is just US data, but, more than 250,000 APIs in the US, 30% were perforated. So obviously by definition, they would have an intra-abdominal infection. 70%, however, are from other sources, perforated viscus of other source, and they're costly as well. They're morbid and they cost a lot of money. So, we deal with them every day. The mortality across the board is anywhere from like 2% to 28% in the literature, but roughly on average about 10%. It really depends on the source, right? And perforated API versus a perforated colon versus like a perforated small bowel. Obviously the perforated colon patients tend to be sicker, tend to have worse outcomes because of the bacterial load. So where do we stand with treatment? How do we define the ideal duration of antibiotics, and can shorter duration be associated with similar results? And I think that goes back to sort of being good antibiotic stewards, right? Do we need to overtreat patients? And is there any benefit of treating longer? So sometimes it was frustrated when I was a resident, you get a patient and everyone would always pick, at least for the US group, we'd always pick football scores, right? Touchdown, 6 points, field goal, you got extra points, 7. Everyone would either pick 7, 10, 14, 21. These numbers were all like, I'm like, well, why is it 7, not 8? Or why is it, where do we get these numbers? So they're all like kind of just rolling dice, and picking a number out of thin air. So that was one way we do it, right? Roughly everyone has like the standard number in their head that they treat with. The other, so the fixed duration, right? We just pick a number and we go with it. The other method is, well, you usually do it until the patient's getting better, right? They're not febrile anymore, their white count's normal. So basing it on like physiologic parameters. So is there a difference? Is one better than the other? Like which one should we use? And which one gives you sort of potentially better outcomes? So I will present you this study. This was one of the first studies that looked at just picking a shorter course of antibiotics. This was a French study out of France, multiple ICUs in France. This is a very, very important study because they looked at, it was a prospective randomized double-blind clinical trial at 51 French ICUs, and they were treating VAP. So we're not talking about a surgical infection here, but they were treating a ventilator-associated pneumonia. And so what they did was they randomized patients to either get 8 days or 15 days of antibiotics of a VAP that had microbiologically proven VAP. So they had the data, they had micro data, they treated them for 8 or 15 days. They evenly distributed patients to both arms. They didn't they let the physicians choose the antibiotic treatment. So the actual antibiotic choice was not sort of dictated in this study. And what they showed was that when they looked at the difference in, this is the Kaplan-Meier curve, looking at the days from total days of sort of survival after VAP, and they saw that there was no difference in outcomes in terms of mortality after 60 days of having had ventilator-associated pneumonia, whether they got 8 or 15 days of antibiotics. So no difference in mortality, no difference in ICU days, no difference in ventilator days. And in fact, what they noted was that multiple resistant pathogens emerged less frequently in those who got 8 days versus 15 days of antibiotics. So that was one of the first studies that showed, like, took two numbers, like, not sure why the French chose 8 and 15, because we always do 7 and 14, but nonetheless, they showed that 8 days was probably just as good as 15 days. So, you know, so that was the whole idea of, like, the first study that looked at, like, fixed duration. And it wasn't, and so I remember thinking this when I was early in my surgical career, just finished fellowship, I was in training, and we were sitting at the surgical infections meeting and talking about this study, and we're thinking about how we can devise a study to look at intra-abdominal infections, because up until this day, the numbers were all over the place. People got 7 days, 10 days, 14 days. So we said, well, we should create a study that compares a fixed duration versus one that looks at physiologic parameters. And that's where we came up with the STOP-IT trial, or the study to optimize peritoneal infection therapy. We got, as a group, we were funded by the NIH to run a 5-year study. This was a randomized trial. And the way we randomized patients was, these are patients with known intra-abdominal infection. Number one, they had to have adequate source control, and that meant whether it was surgical, IR drainage, whatever this method was, that you had to have adequate source control. And they were randomized to either 4 days of antibiotics or until they had normalization of their white count and no fever for 2 days and return of bowel function. So we launched this study in 2008. It took us one extra year than we had initially predicted to recruit enough patients. As you can imagine, this was a hard study to get patients, because even the arm where we had the fixed duration was very short. So imagine 4 days was a big change in paradigm and treatment pattern. So we chose the outcomes that we were looking at. Was the primary outcome was surgical site infection, recurrence of infection, or mortality. So that was our primary outcome. And then secondary outcome was looking at rate of subsequent infection. And our study ended up getting published in the New England Journal of Medicine 2015. So this is called the STOP-IT trial. And what we showed was that you can see that the baseline characteristics of the two groups were very similar. They had sort of similar Apache scores. And looking at the origin of the perforation, we had about a third of our patients had colon and rectal involvement, meaning that they weren't all just, we tried to limit the number of perforated appendicitis in this study. And then you can look at the drainage, how source control was achieved, whether it was drain, resection, and anastomosis, surgical drainage, proximal diversion. So all of those were included, and you can see a fair bit of patients actually underwent interventional radiology as a means of source control. What we showed in our composite primary outcome was that there was no difference in outcomes. There was no difference in recurrent infections. There was no difference in death. Surgical site infections were similar. So the control group was the experimental group was the 4 days. The control group was the patients who got antibiotics till they had normalization of white count and fever for 2 days. And then you can see the length of antibiotics. So the one group got 4 days, which was the randomized 2, and then the other group got 8 days. So the other arm was getting a longer course of antibiotics without any significant improvement. And, here's the sort of looking at the Kaplan-Meier demonstration of the two arms showing equivalent results. So really, so duration of 4 days of antibiotics and intra-abdominal infections after source control gave us similar outcomes. Again, the key I keep reiterating is you cannot apply this study unless you have appropriate source control. And the shorter course was, obviously less exposure to antibiotics over the short period of time. Now, some argued, well, what about patients who came in sicker? Like we wanted to look at sicker patients. So we looked at specifically a subgroup of those patients who presented with sepsis. And we showed, well, maybe they need longer course. In the subgroup analysis, the results were the same. No difference in outcomes between the shorter course and the longer group, even if the patients came in sicker. What about those who underwent IR drainage? What if maybe surgical washout versus IR drainage is different? So, we looked at the subgroup, that third of the patients who had IR means of source control. Again, these are post hoc analysis, so they're all flawed in some sense, but based on we had over 550 patients in that study that were randomized into 2 arms. And there was no difference in outcome between the shorter and longer course. This was that was the stop it trial. And then more recently, there was another study out of France again, that this looked at shorter course of antibiotics for patients treated with post-operative intra-abdominal infections. And this was, again, out of the French ICUs. They looked at doing 8 versus 15 again. They love those 2 numbers, so they went back to 8 and 15. And basically, they showed that these are patients who needed the ICU after they developed a post-operative intra-abdominal infection. Again, no difference in outcomes in both groups. Again, the shorter group, again, but it was 8 days versus the 15 days. And then this is showing, again, the Kaplan-Meier test. This was just showing, this is hard to see, but it was really looking at, different outcomes. The primary outcomes were the antibiotic days, but then like length of ICU time, time in the hospital, time on the ventilator, none of those were different between the 2 arms. Now, what about the immunosuppressed patient? So I gave you 2 cases, one with the immunocompetent patient, one with the one suppressed. Would that be any different? So here's where we run into a lot of lack of data. If you look at the data out there, there's very little data on immunocompromised patient. The reason I'm interested in it, we're attached to a cancer institute here at the Brigham, the Dana-Farber Cancer Institute. So we have a lot of patients we deal with surgical problems that are immunosuppressed, significantly immunosuppressed. There are status post bone marrow transplants and other types of chemo regimens that they come in on. So here, again, going back to our stop it trial, we looked at wanted to see what was the sort of the patients who failed. By failure, we meant recurrence of infection, right? So we wanted to look at what were risk factors that associated with treatment failure. And when we looked at that, and then treatment failure was recurrence of a surgical site infection, or mortality or death. And we saw that use of steroids was one of those things that led to treatment failure or increased higher Apache scores if they came in significantly sicker or colonic source of infection. So overall treatment failure was 22%. And as the number of risk factors increased, the treatment failure increased. However, independently though, so the number of risk factors were independently associated with treatment failure, but the duration of antibiotics was not. So while we know what risk factors led to treatment failure, the ones who got the shorter course versus the longer course had no different in outcomes. Again, so it was kind of the best way we can go look at the immunosuppressed patients, because we didn't have a large group of them in order to be able to do this in retrospect when we look back. But nonetheless, we saw that even in the groups that had treatment failure, it didn't seem that it was related to the duration of antibiotics. This is another study. This is not surgical, but it was looking at bloodstream infections. And this was a study from Hopkins. They looked at ICU patients who came in with Pseudomonas. And, we think of Pseudomonas as a bad infection. These patients are usually immunocompromised and have a lot of underlying medical problems. And they basically randomized patients to shorter course versus a longer course, or 9 versus 16 days of antibiotics. And they saw that these patients had similar outcomes despite the shorter course of antibiotics. And in fact, they were discharged 4 days sooner. And it's important in this study, 65% of these patients were immunosuppressed. They either had HIV/AIDS, solid organ transplant recipients, they were on chemo within the past 6 months. So again, this was the sort of immunocompromised group. So yeah, so no difference in mortality with the shorter course versus the longer course. Now, I say the future direction and something that more people are starting to look at is, well, we talked about picking number of days, and then we talked about shorter is probably okay, but then we don't know how much, what is the right number. So a lot of people are trying to individualize antibiotic duration, looking at biologic variables like CRP or procalcitonin. This was another non-surgical study that looked at looking at CRP to determine duration of treatment for a gram-negative bacteremia, and they looked at using CRP, and once the CRP sort of decreased by 75% from its peak, they would stop the antibiotics. And they actually showed that this group of patients, or it was non-inferior, meaning stopping the antibiotics sooner using CRP, these patients did as well as the longer course of antibiotics. So having said all that, I'm going to go back to this scenario. This is not a scenario I gave you earlier, but this was a patient, this is a trauma patient of mine, blunt trauma, MVC. You can see this is a duodenum that's completely transected. Behind my hand is the head of the pancreas, which is also injured. But this was from the scene, came in, big duodenal injury from blunt trauma. Taken to the OR right away. We repaired this thing, complicated surgery, but nonetheless, what would be, for the purpose of our discussion, what would you do for the antibiotics in this patient? Think about this. So again, trauma from the scene, duodenal injury, significant bile staining. You can see the bile staining in the retroperitoneum here. You can see actually that's bile in that picture coming out from the ampulla. What would you do here for treatment? Would you do a single dose, 24 hours, 4 days, 7 days, 14 days? I know you guys can't participate well, but I would say that the answer is 24 hours. Remember, the East guidelines say that this is a patient that just need perioperative antibiotics, believe it or not. Even though they had significant bile spillage, this actually doesn't qualify as an intra-abdominal infection, because if you can treat it within 12 hours, it's actually not an established infection. So this was a patient that just needs 24 hours of antibiotics, which is sometimes hard for me to convince the residents to stop the antibiotics after 24 hours. They're like, oh, you see all the bile in there or all the stool in there after the trauma? But 24 hours is what the data supports. Going back to our 86-year-old with the perforated colon, the non-immunocompromised patients, I hope that after our talk, you can kind of talk about how many days of antibiotics would you treat here. I know some of you had picked 7 or 14 days, but based on the stop-it trial, the answer is probably 4 days is appropriate. Now, it could be less than 4 days. We don't know. We don't have the data. And that's the next step we should probably try to work on, is can we get away with 48 hours of antibiotics in these patients? Because it may not make a difference. And then back to the immunocompromised host, this is where the data gets a little muddy, and I would give you credit for either of those, but probably not what we normally do with these patients, which is never-ending length of antibiotics because they're immunosuppressed. But you probably, just based on the data that we have, shorter course is probably just as appropriate. And I want to make sure you know that failure or recurrence of infection or surgical sign is not because of antibiotic duration failure. It's probably because of is because you need to get source control. So when you have a patient who develops a recurrent abscess after you've treated the initial abscess or drained the initial abscess, it's really not the antibiotics that failed you. It's probably because you need to get better source control in those cases. All right. I'm going to end with talking about soft tissue infections, because I think this is an area where, again, less common of a problem, but a very highly morbid and more significant mortality when it comes down to. And this is one disease that it is a surgical disease, because the treatment of a necrotizing soft tissue infection is primary treatment is surgery. Antibiotics and such are just secondary. So, we're going to overview it. We're going to talk about some of the controversial areas like diagnosis. We want to talk about, I don't know how many of you are familiar with the Larinic score. Is biopsy useful? What is the optimal time to debride? Should you ever transfer? Think about transferring these patients. And then lastly, my favorite topic, the immunosuppressed patients. What do you do with them? This is a patient of ours that was very unfortunate, 23-year-old who came in with after a bone marrow transplant 12 weeks ago, presented, initially went to an outside hospital with shoulder pain in his axilla. He had strep 2 weeks before, but he was sent home, told to take Motrin, and presented back with multi-system organ failure and septic shock and sort of bullseye all across his erythema, and needed immediate debridement. He had group B strep, necrotizing soft tissue infection. And you can see this is after he was debrided and then ultimately grafted and survived, but significant morbidity with the skin grafts. We all know necrotizing soft tissue infections are surgical emergencies. They can progress quickly, and time is of the essence, and presentation can be variable. And this patient, unfortunately, it was not, was sent home initially after he presented and came back 2-3 days later with fulminant septic shock. They are rare, luckily, but very morbid. Risk factors, I think most of you probably know, again, the same things as for SSI in some ways, diabetics, obese patients, immunosuppressed patients, any kind of traumatic wound is at risk. But they can occur in healthy young people as well. Alcoholic and also IV drug use is a big risk factor as well for developing these. I'm not going to belabor it, but there's basically 4 types. I don't think you need to know the different types. The bottom line is the outcomes are about the same in all the different types. But this question always comes up on our boards. What is the most common organism that causes necrotizing soft tissue infection? And the answer is, most people think strep or staph, but it's actually multimicrobial. So the most common type of NSTI is actually a multimicrobial. So I'm going to skip through like the types, but they're in the lectures if you guys want. But type 1 is sort of a mixture of bacteria, which is the most common type. Type 2 is sort of the strep and staph, usually from IV drug use or recent trauma. And they can present with really significant shock. Type 3 is Vibrio, which is found in fresh water. So puncture wounds found in seawater, actually. I found in our database that these patients had the highest mortality. Like I have a large database of NSTIs over about a 20-year period, and all the Vibrio patients, none of them survived for whatever reason. But so it seems to be a very high mortality with Vibrio infections. And then type 4 are the fungal ones. Clinical presentation can be very broad. Okay? Soft tissue swelling, redness, erythema, pain out of proportion. I think when you start seeing things like skin bulla or necrosis, that's a more obvious sign, crepitus. But they can also present because, remember, the term used to be called, most people still refer it as necrotizing fasciitis. But that term implies that fascia is involved, but a necrotizing infection can involve skin, soft tissue, fascia, muscle, down to bone, right? So the better term, and the nomenclature has changed over the years to just be called a necrotizing soft tissue infection. That's why I use the term NSTI. No longer will I use the term sort of necrotizing fasciitis. So diagnosis, you have the high clinical suspicion, and then timely and recognition, early recognition is critical. So how do you treat it? Treatment is surgical debridement, and then ancillary to that, secondary to that is antibiotic treatment. Generally, because remember I said the most common type is multi-organism, you start broadly with these antibiotics. So you're going to start with covering gram-positives, negatives, anaerobes. Sometimes if you're worried about a toxin-producing organism, you want to add clindamycin to combat the toxin production. So here, talking about the types of antibiotics, I will start with using vancomycin as well, because you may be dealing with an MRSA as well. So remember though, antibiotics are adjuncts. The treatment is surgery. All right, so this is a surgical disease. Now, what are some of the controversial areas? Number 1 is diagnosis. How do you diagnose it? I talked about the physical exam, but you get called about a lot of cellulitis. That's not a necrotizing soft tissue infection. So many years ago, there was a publication that looked at some of the laboratory findings. And interestingly, they saw that a white count, greater than 15, and a sodium, hyponatremia, were associated with NSTI. And when they were present together, that actually increased the likelihood. And this study that was published in Journal of American College of Surgeons in 2000 showed a negative predictive value of 99%. And while it was sensitive, it wasn't very specific. So it was maybe more of a good tool to rule out, but not to confirm. So that led to a further look at these sort of lab values. And this was published by Wong that looked at this, came up with the Larinic score, and that was a laboratory risk indicator for necrotizing fasciitis. And there were 6 independent variables. And I don't know how many of you are aware of the Larinic score, but based on this study, it was like really helpful to use your scoring system. What were the components? Well, the components were this. There was white count, sodium, so hyponatremia, you can see the points that you got for each, a hemoglobin that was lower than 11, a creatinine that was elevated, and a glucose, so elevated glucose. And then the factor that got the most points, you got 4 points if you had a CRP greater than 150. And this is showing you the probability of NSTI as your Larinic score went up. So Wong published this data and said that the sensitivity was 90% and the specificity was 96%. So based on that, like everybody starts on, if your Larinic score is greater than 6 or greater than equal to 6, then it's a high likelihood that you have NSTI. This was based on 80 patients. So it was a small sampling of patients. And this was the sort of Wong's paper that showed, if you have greater than 6, you're really high probability of NSTI. So subsequent to that, we've looked at this in the literature, and we know that the probably is not as sensitive and specific as the initial paper by Wong. It is a good tool, but it's probably not the only thing you should be using to sort of accurately diagnose this. So I know a lot of my residents will call and they say, oh, the Larinic score is 3 or 4, and they don't have an NSTI. So I don't get sort of, you can see that the sensitivity and specificity is, nowhere near where it needs to be for you to just rely heavily on that by itself. And then my question many years ago was, well, what about if they're immunocompromised? Because they may not be able to mount the white count, right? So we looked at this, and I've gathered about a 20-year database of NSTI patients at our institution, and I wanted to look at the immunocompromised patients. So we looked at the way we defined immunocompromised was they're on steroids, they have active malignancy on chemo, HIV, AIDS, or they have a BMT patient or a solid organ transplant patient. And we looked at this group of patients, and we looked at the Larinic scores on them. And we wanted to see, number one, we saw that there was a significant difference between the white count in these two. So we had 40 immunocompromised out of over 200 patients. The white count was lower in the immunocompromised patient, as you would expect. So really, when we used a cutoff of 6, our numbers were quite lower in terms of sensitivity, specificity, and positive and negative predictive value. In fact, the negative predictive value was 50%. It was kind of like not that helpful, right? So definitely the Larinic score has a much lower predictive value in an immunocompromised patient, and this can ultimately lead to delay and possibly explain the higher mortality in this patient population. Now, what about imaging? We use imaging a lot. People will always look for, one of the hallmarks is if you see gas in the tissue, it could be an NSTI. I think CT scans have become more and more in use. It helps. MRI is probably the most definitive because it shows the tissue, soft tissue better. But again, it's time consuming and it's not always available. This was a study that looked at a scoring system for using imaging. You can see here the NSTI scoring system. So the component that got the most value was if there's air in the soft tissue. The rest was like edema or fluid tracking, and they looked at sort of what is the percentage of or probability of NSTI if you had a score greater than 6. So highly sensitive and specific. So again, imaging can help you. Ultimately, this is a clinical diagnosis. So you got to use your labs, you got to use your imaging. But oftentimes when you see an NSTI, you can often just diagnose it by examining it and seeing the clinical picture. Another area where I was always had questions with was what about sometimes you take a patient to the OR and you're not sure, is this an abscess, is this an NSTI? I think one of the hallmarks of NSTI is there's dead tissue, right? There's not bleeding, it's necrotic. This positive finger test is where you can take your finger and all the soft tissue kind of falls off on its own because everything is dead, right? That's the hallmark of an NSTI. In the past, I remember when I was a resident, we used to send biopsies of the fascia to try to determine if we should take more. And so I wanted to look at that. I partnered up with our pathologist and we looked at our frozen section data, and we saw that it was pretty unreliable to diagnose necrotizing soft tissue infection. So you don't need a pathologist to tell you whether or not you have an NSTI. It's a clinical diagnosis that you should be able to make in the operating room. Really won't bore you with the algorithm, but the bottom line is, you can use the labs, you can use your imaging, but at the end of the day, if you have any concerns or questions, you should go to the OR. In the operating room, you can see dead tissue. You know that you're dealing with a necrotizing soft tissue infection. In the last few minutes, we're going to talk about optimal timing. When is there an optimal timing for it? There is, and basically this is a consensus statement, guidelines from East that says that treatment should be within 12 hours because mortality is significantly lower if you can treat these patients early on, and early being defined as less than 12 hours. Mortality doubles almost when you go later, beyond 12 hours. Now, again, back to the immunocompromised host, we looked at this data and looked at outcomes in general there was no data on the immunocompromised NSTI patients when I first looked at this. And that's why I was very interested to see, what is the outcome in these patients? So again, we looked at this, we had this large database of 200 patients, again, same inclusion criteria for immunosuppression. And what we showed was, first of all, patients, both immunocompromised and immunocompetent, tended to present with similar physical exam findings, right? So they actually presented, but fewer than 50% of these patients actually had the hard signs of NSTI, which is bulla, crepitus, skin necrosis. So you don't need to have that to have an NSTI because it may just be early on and you don't have the skin necrosis visible yet. And also look at this data on gas on imaging. Only 50% had gas on imaging. These are all patients that had necrotizing soft tissue infection. So you don't have to have soft tissue gas. And then and we showed that the white counts were different, again, same group. And then we looked at time to the OR, time from presentation to diagnosis and time from presentation to the OR, and saw that these patients that were immunocompromised had delay time to diagnosis and had delay time to the OR. So generally later in diagnosis. And as you can imagine, mortality was double. So we had 40% mortality in immunocompromised patients, 20% in immunocompetent patients. And lastly, we get a lot of transfers here. I know the system of hospitals is probably different where you guys are. And I don't know how much transferring happens between hospitals per se, but we get a lot of the smaller hospitals will transfer their NSTIs to us. And the question is, I did mention that early debridement, better outcomes than late. So the question is, should you transfer these patients or treat them at your hospital and then transfer them for post-op care? This is an area that I think is still controversial, but this was one published study that tried to look at whether transfer status made a difference. And they looked at NSQIP database of over a 5-year period, and 31% of the patients did transfer, and they saw that the mortality wasn't significantly different. So you can see that the non-transfers, the gray bar, mortality was slightly lower, but it wasn't statistically significant. So there's a trend towards better outcomes for those patients that were not transferred. And there's also overall probably less morbidity, but again, none of these ended up being statistically significant. So I think this is an area that I'm actually looking at on our databases again as well, because I'm not convinced that, transferring doesn't cause worse outcomes, because there definitely seems to be trends towards worse outcomes. And also it really depends on, I guess, how far you're transferring and how long it takes to do the transfer. And lastly, just nutrition is important. We treat burn patients with aggressive nutrition. And in my mind, an NSTI patient is very similar. And these patients should be appropriately get good nutrition upfront and early and be aggressively treated. And there's very limited data on this, almost none. But this was one study that I found that showed, in a retrospective study, that they took 85 patients with NSTI. Those who got enteral nutrition 48 hours or fewer had better outcomes, shorter hospital length of stay, less infections, overall no mortality difference, but you can see less ventilator days, less infection. Again, retrospective study, not great, but really not dearth of information on this patient population. And then lastly, I was interested, so obesity is a risk factor for NSTI. And when we looked at our data, actually, believe it or not, NSTI, obese patients with NSTI did better. They had better outcomes than the underweight. Actually, the group that had the worst outcomes was patients who were underweight. So while obesity seems to be somewhat protective, it's a risk factor for NSTI, but then when you get NSTI, it seems to be somewhat protective. So remember, a hallmark of NSTI is sort of, you're going to get destruction of tissue. Remember, the infection is usually polymicrobial. So treat broadly with your antibiotics up front, get cultures and narrow your coverage, be good antibiotic stewards, and then early surgical debridement is important. And then I guess in conclusion, I want to say surgical infections are a big problem. Resistance is even a bigger problem as we're having more and more issues with antibiotic resistance. So all of us, including surgeons, could help with the, be good antibiotic stewards, both not in using prophylaxis appropriately, but also treatment. And longer course doesn't usually mean better outcomes. And then immunocompromised host is an area where it's an added challenge. We still don't have a lot of data to support what we do, but certainly these are much more complicated patients. And with that, I would like to thank you and have some time for questions.
Thank you very much, Dr. Askari, for this wonderful lecture. A very, very important topic for Ukrainian surgeons nowadays. If you have time for a few questions, I would give a word to Hassan El-Kafarna, please.
Thank you, Doctor, for the great lecture. I have two questions. The first one, do you have a local protocol for antibiotic prescription for patients with gunshot wounds? If so, could you share it with us, please? And do you consider previous antibiotic intake in those researchers for antibiotic treatment?
First question, we don't have a specific protocol. I think it all depends on the gunshot wounds and what it entails. Like, is it an area that, again, intra-abdominal gunshots that you just need 24 hours of antibiotics if you have source control. If it's obviously wounds that are soft tissue wounds, then generally I don't treat them, again, a very long time at all. I would just leave the wounds open and treat with just local wound care often. So the second question was if they had been treated previously with antibiotics, if it alters what we do. No, not necessarily, other than you have to think about resistance patterns that they may have. So one of the things I always do intra-op is if I have perforation, I always culture it because I want to know not so much what's growing, but what's not growing. Like, are they going to have any resistant organisms, and such? So people always say, well, why are you culturing a perforated colon? It's just going to be stool. Like, why are you culturing stool? But I want to know if they have candida in there. I want to know if they grew any other, extended spectrum beta lactamases, which goes back to your question. If they've had antibiotics before or recently, they may actually have some resistant organisms. So your antibiotics that you give them actually does nothing because you're not treating the resistant organisms. So I do strongly encourage culture and then following your culture data.
Thank you, Dr. Askari, and please ask by one questions because we are already running out of the time. I guess we have two questions. Victor Chervonochenko, please.
Dr. Askari, thank you for your lecture. My question is, do you have an microbiological profile in your hospital? Do you know your hospital's flora? And when you, if so, does it change or the antibacterial prophylaxis in your before surgeries in your hospital?
Excellent question. The answer is yes. We have data on our flora. We also have like a hospital pharmacist that helps us, especially when I'm in the ICU, managing patients about sort of treatment, especially when we're starting sort of broad spectrum. And generally for prophylaxis, I won't change unless I know they have like MRSA or like they have a known diagnosis. Otherwise, I don't change the prophylaxis. We have obviously a prophylaxis guidelines for in a hospital as well that we use. But I think the antimicrobial antibiograms are very, very important when you're treating patients on the floor post-op infections, because then you're dealing with hospital-acquired infections often.
Thank you, Dr. Askari. And last question to Smirnova Margarita, please.
Thank you very much for your presentation. And I have one question. Do you use a hyperbaric oxygen therapy for patients with infected wounds in your daily practice?
Great question as well. There's very little evidence that you need hyperbaric oxygen therapy, that it doesn't really, I mean, you could probably find a paper or two that shows benefit for soft tissue infections, but I don't believe it makes a big difference. I think as long as you've adequately debrided the patient and you resuscitate the patient, often there's not much benefit to that. But again, having said that, there's a lot of studies that show no benefit, but I'm sure you can find a few that show some benefit, but I don't think it's needed. We have one at Mass General. I've never in my 15 years here sent anybody there for it. But again, people that have it will use it and they swear by it. They're like, oh yeah, it makes a big difference. I don't think it's actually borne out in any real good evidence. That's a great question, especially when you're dealing with dirty wounds. That I think the key is surgical debridement. Like you have to be aggressive, debride the healthy tissue, and then the rest is up to the patient. And good nutrition, good resuscitation, good support to get them better. I have time for more questions. I don't want to cut it short. So.
Oh, great, Dr. Askari. Then we have a few more questions from Dr. Nozdrin, please.
Thank doctor for the great talk. And I wanted to ask about antibiotic prophylaxis. Do you use a second dosage of antibiotics if the patient have intraoperative bleeding? And if so, if there are any threshold, like 500 cc's, 1 liter, is there any data about that?
So another wonderful question as well. And that's something I'm trying to study now, because we're trying to get samples. I was trying to get funded, which I didn't, was unsuccessful in getting funded for that exact project, is to look at patients who have massive resuscitation and bleeding. At what point should we be prophylaxing them? The answer is we should be. And I don't know the right number is. Like, was it 1 unit, 2 units, 500 cc's? I don't know. But I can tell you that we probably should be. And I'm trying to collaborate with some people to actually do that exact study, to actually get samples to see where the antibiotic level is, what's the concentration after a certain blood loss. But I don't know the answer to that. I would say that we should. And, one of the things the guidelines say you should redose your cephalosporin in 3 to 4 hours anyway. Obviously, if you have a gunshot or a massive bleeding patient, you shouldn't be in the OR that long anyway. You should be getting them out of the OR to damage control. But I do think it's probably we're underdosing those patients who have massive exsanguination.
Thank you, Dr. Askari. One question from the chat. Dr. Mishko is asking, we don't have neomycin in Ukraine. Should we use erythromycin for colorectal surgery instead? Are there other alternatives?
Yes, you can use, certainly can use erythromycin and metronidazole. The problem with erythromycin is that it interacts with a lot of other medications. So often it's hard to give to patients because they're on other stuff that it often will interact with. But certainly you can use erythromycin. And if you don't use anything, you can still use just metronidazole to decrease the bacterial colony intraluminally.
Thank you. Next question from Dr. Boyarsky.
Thank you for your lecture. My question is about, do you use antiseptics for irrigation subcutaneous tissues before closing for clean wounds?
No, just irrigate. I don't think there's any data that's borne out to say, like, I know common practice, people use all sorts of, like, orthopedics pour in vancomycin powder. I mean, some people like to wash with betadine fluid, like there's all this practices that I've seen over the years. Based on the data we have, probably there's no evidence for it. I know, but it's hard practice to change. A lot of people love to irrigate with bacitracin and stuff like that with these wounds, but I don't think you need to. As long as you have good prep before, you have good prophylaxis, and you don't break sterile technique, I don't think you need it.
Thank you, Dr. Askari. Question from Dr. Lisecka.
Thank you so much for your lecture. My question is it effective to use extra operation fields at each stages, like before the aponeurosis excision and peritoneum excision, and changing gloves before the mesh placement? Does it decrease the risk of wound contamination?
I think in theory, yes. I don't think there's any studies that have been done specifically to answer your question. But yeah, I mean, I think if you're doing, certainly we'll do like a bowel surgery and then you're going to put mesh. I think everybody irrigates and changes gloves. I think it's a good practice. I don't know if it makes a huge difference at the end of it. It's just hard. It's a very hard thing to study, so there's really no data on it.
Thank you, Dr. Askari. Question from Dr. Hopa.
Thank you for your lecture. I have one question. Do you use penicillin now for treatment or prophylaxis? And how it effective if you use? And in our hospital, we see what is effective. No, again, the same before.
Sorry, I think she cut out. What was the question? Do I use penicillin? I think it was hard to hear because it was cutting in and out. Did you get a sense, Ali? What?
Yeah, I'm thinking she's asking whether you still use old penicillins, right?
Yes,
yeah.
yes.
How effective they are.
Yeah, that's a great question. I think don't use penicillin anymore. We use like the cephalosporins usually for prophylaxis. I do use penicillin, high levels of Pen-G actually for soft tissue infections, especially if I think it's strep or staph. When you get like a septic shock type infection of NSTI, and Alvin will load them with Pen-G, because actually the best treatment for a bad strep type NSTI is actually Pen-G. And I also will use clindamycin, because clinda is ribosomal, affects the ribosome production of protein, so it actually affects the toxin production of the infection. So I still use penicillin, but only in that setting. Generally don't use penicillin outside of that, because there's so much resistance to generally for general penicillin.
Thanks, Dr. Askari. A question from Dr. Michalnyuk.
Thank you, Dr. Askari, for your lecture. In my practice, we have a few patients, and in their microbiological profile, we have obtained Acinetobacter baumannii, and this microbe had resistance to every antibiotic that we have. What we should do in this case?
Yeah, I mean, I think in that setting, that's why there's millions of people still dying from resistant infections. I think that those are settings where it becomes a challenge, because then you probably don't have anything in your armamentarium to treat them with. I guess the question I would have is, where are you growing this? Is this like an abscess that you've drained, or is this like a perforation that you cleaned out? In those settings, I think you probably can still get away with just good source control and good drainage. It's different if you have like a pneumonia with a very resistant organism. In those settings, I don't think there's a lot of good options. But I think, I think that's what it gets back to, that 4-day, the stop it trial. I don't even think 4 days is needed. Like, I think you can get away with almost 24 hours of antibiotics. I'm not sure how much the antibiotics help after you've been able to obtain good source control. And I think that's we don't know what the right number is.
Thank you, Dr. Askari. And we have last questions on the chat. Do you use adhesive drapes with antimicrobial properties?
No, nothing fancy over here. No, we don't use any of that. I mean, some people would still use Ioban to cover their area that they're going to operate on. I don't even know, thoracics uses that. The neurosurgeons use a lot of that. I don't know if it makes a difference in overall outcomes, So
thank you for your answer. Next question. What antiseptic do you use for skin preparation before surgery? Do you repeat application of antiseptic agents to the patient's skin immediately before closing the surgical incision?
So there's the data that shows, chlorhexidine preps, alcohol preps are better than betadine and iodine preps. Obviously, you can't use those in patients with open wounds, so you still have to use betadine, iodine preps. I don't repeat the application because, again, most of those alcohol-based ones you can't use on open wounds anyway. So whether you squirt more iodine or betadine on a wound, again, I don't think that those practices have ever been shown to make a difference. After pre-op, yes, like antisepsis works, but after that, and I think there was a question about what do you do for contamination? I just irrigate a lot. So, intraoperative abdominal contaminations, perforated viscous, you go in, I use about 4 liters of warm saline. Hypothermia is a big thing, keep your patients warm. That makes a difference when we look at data and surgical site infections afterwards. Hypoxia is another one, like keeping the patients oxygenating well actually makes a difference. Subtle differences, very small, but there are differences that data has borne out.
Last question, I think, do you use decametoxin do you use the decametoxin?
I don't know, we don't use that. I think Anton has a question. I saw his hand raised. Is it Dr. Kolpak? Is that right? Yes. Did you have a question?
Yeah, thank you for your lecture. And I have a question about post-injury antimicrobial agent selection and duration. Question is about preferred agent when you have skin, soft tissue damage with open fracture. Will you use cefazolin? Only cefazolin, or you will add metronidazole to cefazolin too, if you will have, for example, grown contamination of wound with open fracture?
So open fractures, yes. So open fractures, you have to be aggressive. You want antibiotics within 60 minutes. ANSEF for grade 1 and 2 dirty wounds, but if it's like a soiled wound with soilage, significant soilage, then we use something like some more broad spectrum. So Zosyn is our hospital recommendation. So yes, definitely cephalosporins work, but not if it's really dirty. Then especially if it's a combat wound, I think you're gonna probably want to, especially for open fracture, you're gonna be using more broad spectrum for sure.
Thank you very much.
Yeah, I mean, old days we used to use like ANSEF, cefalozone, and gentamicin. We've gone away from gent because of all its toxicity. So, as from that standpoint, I think we just use like Zosyn as a single agent. They're very broad spectrum.
Thank you very much, Dr. Askari, for this amazing lecture. High-yield topics covered in such a short amount of time. Thank you for contributing to the rebuilding of Ukrainian healthcare. We all enjoyed your lecture, and thank you again for joining us today.
Thank you all for inviting me. It's been a pleasure, an honor. Thank you.
Thank you very much.
Thank you.
Thanks.
Thank you.